Well, welcome everyone. Today I have with us a very prominent medical journalist. His name is Robert Whitaker, and he has written for some very impressive publications, and actually he was a nominee for a Pulitzer Prize. And he's focusing much of his work nowadays on an area that is really near and dear to what we're teaching on our side, and that is the use of drugs in psychiatric drugs and some of the natural course of history of typical psychiatric illnesses. So we're going to have a very amazing discussion very shortly. But before we start that, Robert, why don't you let our listeners know some of the publications you've written for and some of your journalistic achievements?
Sure. I was the medical reporter at the Albany Times-Union for a long time. Then I was the director of publications at Harvard Medical School for a while. And then I did a lot of freelancing for magazines and newspapers, and a series that I wrote related to psychiatry for the Boston Globe was actually a finalist for the Pulitzer Prize in 1998. And then in the past 10 years, I've been writing books. My first book was titled Mad in America, and that was a history of the treatment of the severely mentally ill. And my latest book is called Anatomy of an Epidemic, Magic Bullets, Psychiatric Drugs, and the Astonishing Rise of Mental Illness in America. It's published by Crown, and it's newly out.
Well, thank you for that, Robert. And what I'd like to focus on now is really the use of the typical approach that traditional medicine has when it comes to psychiatric illness. Most of the information that we have on our site is really focused on natural adjustments to your lifestyle, and this is primarily physical things. But there's just no question. I've been a physician for almost 30 years now, and it's very clear to me that some of the most important contributions to health and illness is really the emotional energetic component. And you can eat the healthiest diet in the world, have the best water, drink the best water, basically remove yourself from all toxic influences. But if you have emotional challenges, it's definitely a problem. So I appreciated this actually when I finished medical school. I knew that, I understood that really well, and actually became enamored with treating depression because it's such a pervasive issue and really one of the most common mental illnesses. And depression, it can be a terminal illness. People die from suicide every day. It's not commonly appreciated. I mean, people know people that commit suicide, but they don't realize the precursor for that is depression. So it's got to be a pretty miserable feeling if you're willing to kill yourself over it. So obviously there's a significant need here. The traditional approach has sought to use drugs to address this need, and we believe that there's far better efforts. So I think what I'd like to discuss with you today is really creating some ammunition that many of our listeners can use to justify the approach and seeking a natural alternative to the conventional approach, which is using these drugs, and that in many cases, a lot of the recent studies, and I'm sure you're familiar with them and can expand on it for us, perform no better than placebo, and are not without side effects. So why don't we start there, and we can start the discussion there.
Sure, and I think the ammunition I can provide is, what does the research literature show, both in terms of short-term and long-term, in terms of the effectiveness of this sort of pill-oriented approach. Right now, we've had a lot of talk about whether antidepressants are more effective than placebo over the short term, and those are in 6-week trials. And in those trials, what you see is that at least for mild to moderate depression, basically the drug-treated group doesn't do any better in any sort of clinically significant way in terms of relieving the target symptom of depression than the placebo group. So, and as you said, all drugs have this benefit-risk ratio. So if you're not getting a benefit over placebo on the target symptom in this mild to moderate group, you really don't have a good rationale to use these as a first-line therapy. Maybe you're going to use them as a second line if other things don't work. But that's, our focus right now is on the short-term efficacy, and it's sort of questionable. But I think what your readers and your listeners need to know is what happens long-term. What's the effect of antidepressants on the long-term course of depression? And that's one of the things I looked at in this book, and there's really two things you find. You find that even with major depression in the pre-antidepressant era, and this is depression so severe people were hospitalized, they could expect to get better. The episode would eventually pass, usually for most people, in 6 months, 4 months, 6 months, 8 months, etc. So when antidepressants were introduced, the thought was, okay, we really can't hope to improve on this sort of natural recovery, but maybe we can help people recover quicker. And so that really was the rationale for the use of antidepressants. But it's really interesting if you follow this course through and forward in history. The minute they start using antidepressants in any sort of large numbers, doctors start saying, well, my patients may be getting better, the depression may be lifting faster, but then we're noticing that they're also relapsing more frequently than before into depression. So right away you get this question: does a drug treatment actually put people on a more chronic course than before? And if you follow this epidemiological story forward, again, people used to have an episode, they would recover, and then maybe 2-3 years later they would have another major episode. Maybe they wouldn't at all, or maybe another 10 years. It was very much like, in a sense, like the flu would visit for a time and it would take some time to recover. Now people are much more chronically ill, and what seems to happen is they're put on an antidepressant, and maybe the symptoms abate somewhat, but they don't remit all the way. And what they found is that in those percentage of people that it doesn't remit all the way, they start heading down a chronic course. So now, for example, if you look at the long-term literature, what it shows is that with major depression, only about 15% of patients that are treated with an antidepressant remit and stay well basically for a long period of time. The remaining 85% start having this relapsing course, and it just becomes much more chronically ill. And by the way, by the 1990s, this change in the long-term course of depression was so pronounced it finally actually was addressed by researchers. And there was a guy named Giovanni Fava from Italy said, hey, listen, the course is changing with antidepressants. We're changing it from an episodic illness to a chronic illness, and we really need to address this. And it seems like not only that, the depression is sort of sinking into people in a sort of a deeper way than before.
Now, when you say seeking into people, this is the general population or those individuals who are placed on medications?
Those placed on medication.
Okay.
So it's almost as if, as Fava says, it's almost as if the drugs sensitize people to depression long term.
Okay, I'd like to interject a point here, and I think it's valid to the discussion with respect to the chronology of the antidepressants. And as I mentioned earlier, one of my passions when I came out of medical school, and admittedly I was founded and rooted in the conventional paradigm, was not practicing natural medicine. And one of my primary focuses was on depression, and I became very skilled at using the drugs to treat depression. Now, this is in the mid-'80s, and the drugs available in the mid-'80s, 25 years ago, were significantly different than the newer ones that came out, which were exemplified by Prozac, which is a SSRI, but it's really based on fluoride. So, and the biggest primary symptomatic difference was that these drugs, for the most part, did not have perceivable side effects. Using the drugs prior to the SSRIs was like a nightmare, and the biggest clinical skill that one had to get was to really understand how to carefully adjust the dosages to minimize the side effects so that people could tolerate them. Like with amitriptyline or Elavil, you have this tremendous dry mouth. It's really potent antihistamine and other side effects with it. So I'm wondering if your research has shown that this shift from those drugs which had made it very difficult for patients to take long term to these easier ones without really annoying side effects, at least acute side effects, was responsible for some of the differences that you're seeing.
No, I think actually it's pretty, I know exactly what you're saying, the switch from the tricyclics to the SSRIs. The chronicity seems constant in any sort of long-term outcome studies. In other words, it starts showing up with the tricyclics, fairly early on, this switch to a chronic course, but it's also now seen in people treated with SSRIs. And the problem is with major depression, so in other words, there's been studies by the NIMH in the 90s after Prozac that involved with the SSRIs, and they find the same thing. You get a stay-well rate of about 15% maybe, and the other 85% end up with this relapsing course. And it's really interesting if you read the APA and American Psychiatric Association textbook, like I think it's like the 1999 one, they say, we used to think people would get well and that the long-term course of major depression was pretty favorable. But now we're seeing that it's a chronic pernicious disease, but they're talking about medicated depression, not unmedicated depression.
Very important distinction. So, and this appreciation developed in the mid-90s? Is your
Yeah, and here's what happened. So you have this guy in Italy named Giovanni Fava saying, I think we're sensitizing the brain to depression long-term with these drugs, okay? And this is the first major problem. And a very famous psychopharmacologist named Ross Baldersarrini at Harvard Medical School, he's one of the fathers of psychopharmacology, says, we really need to investigate this. This is what our research is showing. He says it's not pleasant to consider, but we have to look at this. Are these drugs depressogenic? And then there was a response by a psychiatrist at Columbia University named Donald Klein, and he says this: listen, stop talking about this. Nobody's interested in this question. The FDA is not interested. The NIMH is not interested. Nobody is interested. We're just not going to investigate this, and you don't see the research done that would investigate it. And that's the moment you can really see psychiatry sort of betraying its patients, because here you have mainstream people writing about it. Seems like over the long term we're turning depression into a chronic course, that maybe these drugs in fact are depressogenic over the long term. Major guys saying we have to investigate this, and now here's another major psychiatrist in America saying, stop talking about this. We don't want to even think about this.
My suspicion is that the first one was an honest, high-integrity clinician who wasn't necessarily in massive conflict of interest through subsidies through the drug companies.
Well, you're exactly right, and that's what he writes back. This dialogue actually happened in writing, and Fava writes back, well, maybe you're not interested where you're under the influence of pharmaceutical companies, but we're interested, and we're going to keep on trying to understand what's going on. But that, in terms of, obviously, I think when people have a major depressive episode, they do have two desires. One desire, of course, for the depressive episode to, terminate, get out of that, that awful feeling. But then they also want to think, how am I going to do long term? And they need to know the long term information as well. And long term with antidepressants is a very sort of discouraging course. Mm-hmm. And by the way, and you were talking, we can go into this in a bit. Because Britain actually is starting to switch its recommendations in terms of how you treat depression. But you talked about natural lifestyle changes or things you can do to recover from depression. And there was a study by Duke University Duke University researchers in the late 1990s that had this, and this one really needs to be known. It had this design. It had three groups. There was exercise only, exercise plus drug, and drug only, okay? And after 6 weeks, the drug-only group was doing a tiny bit better than the other two groups, okay? Then they followed up for 10 months, and their hypothesis was that the best stay-well rate would be seen in those with drug plus exercise. But in fact, by far, it was in the exercise-only group, and therefore, on the long term, actually the drug being added to exercise was a hindrance to long-term stay-well rate, and a notable one, by the way. So there's an example of what is sort of a natural or healthy thing to do to recover from depression. Duke University's researchers looked at this. They said, wow, exercise can help you sort of respond acutely, but then it helps you stay well in addition. And just so you can see how mainstream this is becoming in Britain, Britain has an advisory group to the National Health Service called the NICE, the National Institute of Clinical Excellence. And it recently, or I think it was about 4 years ago, issued a paper on depression. It said, at least for mild to moderate depression, antidepressants should not be a first line of therapy. They're just not that effective even over the short term, and as you said, they have all these side effects. So we need to look for alternatives. And one of the things they said is exercise, such that now in Britain, you can actually go to your GP, and the GP, and you tell your general practitioner that you're depressed, he'll write you out a prescription for exercise. And with that prescription, you go and meet with an exercise counselor. That exercise counselor sets you up with a program, usually at a gym, because they also believe in additional exercise, it's good to be in social groups, community groups. You now get either a reduced rate or a free rate at a gym for 6 months. Part of the exercise might be green gyms, and by that they might be gardening outside, nature walks, repairing trails, hiking trails. And they are finding that, people really like this. People comply with it. As you know, lots of people won't stay on antidepressants. And what they say is, when they've done interviews with people who've gone through this course and been prescribed exercise, they say, rather than see themselves as a victim of depression and helpless before it, that they have this sort of biological problem they can't do anything about, they say, aha, I can make a change. I can do something. It's in my willpower. and to do something that will help this problem, lift, this mood lift. So it empowers the patient in a different way that drugs do not.
Well, that's very exciting to hear. When did they implement that program in Britain?
Well, they've been trying to get GPs. It goes back about 5 years ago when they started mounting. No, that's wrong. Sorry. It was in 2007. The Mental Health Foundation there started running a campaign alerting GPs to the literature that they could, in fact, GPs there have been able to prescribe depression for other physical illnesses as part of the rehab. And now they started alerting GPs, use it for depression too. Take advantage of these already existing programs.
Prescribing exercise.
Prescribing exercise, excuse me.
Yeah.
So they mounted this campaign in 2007, and the number of doctors now GPs prescribing exercise has increased from around 4% 2 years ago, and it's up to about 25% of all doctors in Britain. And of course they want to keep this publicity campaign going and really make it a sort of a frontline therapy.
Well, that's very exciting to hear. I've not heard that before, and it's encouraging. It's somewhat shocking and surprising to find out in light of the tremendous influence that the pharmaceutical companies have over that approach, and really a serious loss of revenues. I mean, when someone's on exercise and they're not taking drugs, it's a loss of revenue. So there's going to be, I would imagine, an effort to thwart that type of intervention.
I'm sure there will, and there is a lot of pharmaceutical influence with doctors in the UK as well. But, of course, the UK has a National Health Service, and they've been spending ever greater amounts of money on antidepressants. So from that angle, they want to actually curb their spending on antidepressants because it's not giving them good results, cost-efficient results.
And I'm a really strong proponent of exercise. I've been personally exercising for well over 40 years and was actually one of the reasons why I went to medical school, to use it as a therapeutic modality. What I've learned, though, is that even though it's useful, and there's a lot of specifics with exercise because there's so many different ways. There's like 5 or 6 primary different types of exercise you can use, and they're all valid in their own way. But what I've learned is that there's other modalities, such as the foods that you're eating. If you're eating foods that are really high in processed foods and high in these sugars, that's going to move your production of your neurotransmitters to the point where they're relatively unhealthy. And unhealthy fats is another issue, or to have fat deficiencies such as omega-3 fats, or a high concentration of highly damaged and toxic omega-6 fats. So these are all other elements, physical elements, that can clearly have a major influence on one's ability to contract a mental illness like depression, or certainly any of the others.
I didn't investigate this a lot, but when I was doing my research on depression, one thing I found was very interesting was the sense that depression really is a mind-body illness. And by that I mean is you do see it take hold in people who are not that physically healthy. And whether that be from diet, lack of exercise, etc. So, again, you're much more prone to depression, and for whatever reason, if you're not in good health, and eating the wrong foods can obviously contribute to that. And obviously one of the things that's happening with exercise, it's improving your overall health. Mm-hmm. And one of the things that's happening with the studies on exercise, they're even showing that as your aerobic capacity improves, which is a sign of health, there's a pretty good connection to the lifting of mood with aerobic capacity. So there's a sense that depression just doesn't take hold in the mind, in the brain, that really it's this mind-body thing that happens, and that good health, good physical health, can certainly lower your risk of developing depression in the first place.
Yes, indeed. And I think that the newest focus in exercise is, as I mentioned, that's one of my passions now, is in this anaerobic capacity, your ability to do these short-term bursts, which is much more physiological than what we see in nature and the way animals exercise. I mean, it's very unusual to see an animal running 20, 30 miles at a crack. Right. Typically I do these bursts, so I think incorporating more of those types of exercises could be pretty healthy. But eventually, you can do all of these healthy lifestyle changes and really have an almost perfect approach and still have significant mental emotional trauma. And that is because we're in a world that imparts that on a regular basis. It's just hard to live without encountering some type of challenge. And what I found to be effective in my clinical practice is the use of these energy psychology techniques that are very useful. They're used by over 10,000 psychologists. It's not as commonly used in the psychiatric community, but they're simple tools where they but best represented by meridian tapping techniques or emotional freedom technique, where you tap on these meridians and you essentially activate different memory traumas in the system and reframe it and improve that electrical circuitry so that these types of illnesses can improve dramatically. That they're really quite simple to do. The challenge with many of them, though, is that they are because they're so simple, the average person who's untrained in them thinks that they could do it themselves, and really there's a significant art to it. So, for serious illnesses, as depression clearly can be, if you're going to kill yourself, then it's certainly wise to seek out a skilled professional who can assist that person. But these other tools and options are clearly available. But what I'd like to focus on too now is you've really compiled, you've done your homework, you've put out probably thousands or tens of thousands of hours into studying this issue very carefully. And if you can enlighten our listeners as to, aside from the central point which you just brought up of going on these chronically to actually developing a depressive symptom as a result of taking the medication, some of the other side effects or concerns that one needs to be alerted to by choosing that route.
Well, we hear about a lot of side effects, sexual dysfunction, etc., and maybe sleeplessness, that sort of thing. But I think there's two side effects or risks that really need to be addressed, and that everybody should be thinking about, that do show up in the scientific literature. The first risk is, in fact, that you'll convert, quote, from unipolar depression to bipolar depression, and you definitely see this, that the drugs are meant to rouse, right? That the risk of having a manic episode or a quasi-psychotic episode when you go on an antidepressant is real. And so one of the things we've seen with the use of the SSRIs, of course, is this incredible, extraordinary boom in bipolar diagnoses, and that is definitely tied to the widespread use of antidepressants. Now, in kids, something like 25 to 50% of all kids placed on an antidepressant who stay on that antidepressant for 5 years will convert to bipolar illness. With adults, it seems like about 25% of long-term users that begin with, a diagnosis of unipolar depression will convert to bipolar. Now, bipolar used to be a fairly rare disorder, but now it's becoming much more common. And now, why is this so bad? Well, when you convert from depression to bipolar, now you're in a category where you're often treated with a cocktail of medications, including an antipsychotic medication, and long-term bipolar outcomes are really problematic in this country. Only about 35% of bipolar patients now are employed. So you see this risk of disability. Bipolar patients today do a lot of cycling. So my point is this: when you go on an antidepressant, you do have a risk of having a manic episode, and that is a risk of becoming, quote, a bipolar patient, and at that moment you're into a much more long-term problematic disorder with not a good outcome today. That's the first risk. The second risk, and at least people should appreciate it, the second real risk is that there is a lot of evidence compiling that if you stay on antidepressants 5, 10, 15 years, there's some real worry with cognitive decline associated with that long-term use. Now, it's not as fleshed out as we might like, because of course no one's paying to study cognitive decline. But as one researcher at Massachusetts General Hospital said, when we look for it, we find that it's quite common. So that I would say that's a real concern. And I think the marker for this, if you talk to people who've been on SSRIs a long time, they'll often say, my memory's not very good anymore. And memory is sort of the canary in the mine in terms of a very visible sign of some, cognitive decline. Mm-hmm. So I would be worried about that with any long-term use. And those are two risks that tell of long-term significant harm done.
There was actually another clinician at Mass General who advocates the use of omega-3 fats for the treatment of depression. And actually, his book was written a while ago, but it was really one of the more popular ones. And it would make sense, too, because that the population that was deficient in omega-3 might be more predisposed to the depression, but the population would be more predisposed to developing chronic degenerative neurological diseases like Alzheimer's. So, it makes sense that they're correlated, and may not even be necessarily caused by the medication, but it's certainly not going to help it once you're introducing something that clearly is only designed to treat the symptoms and in no way, shape, or form addresses the underlying reason as to why that person is depressed.
No, I mean, this idea that they fix a chemical imbalance is, scientific nonsense. I'm talking about SSRIs.
I totally agree with you, and perhaps you can, I suspect you've really researched that well, and that is the current theory, that there's this chemical imbalance, quote unquote, that exists within your brain, and these drugs are going to correct that imbalance, and it's a really brilliant marketing metaphor. And I'm wondering if you could expand on that, because I think that really is the justification that most physicians are using to put people on these drugs.
Yeah, I think this is important to understand, because it ultimately it is a marketing statement. It's not a scientific statement at all. And in this book, I do trace where that arose from. And let's just say the low serotonin theory of depression. That theory arose because they understood how the drugs acted on the brain. So this actually arose before Prozac's arrival. But say they understand that a drug blocks the reuptake of serotonin into the presynaptic neuron, and therefore keeps serotonin longer in the synaptic cleft. Well, researchers hypothesized, based on that mechanism of action, that people with depression, since it was keeping serotonin longer in the cleft, that people had low serotonin. But it was just a hypothesis born to try to explain why the drug might be fixing something. They investigated whether people had low serotonin. They really did these investigations in the 1970s and early 1980s. This is NIMH-funded researchers, and I could go over that research, but I will tell you what they concluded in 1983. NIMH concluded basically there is no evidence that there is anything wrong in the serotonergic system of depressed patients. Okay? And this was in 1983, before Prozac is released. So there was never evidence that people with depression characteristically had low levels of serotonin. As one doctor I interviewed about this, who did some of this research, said, the serotonin theory of depression is comparable to the masturbatory theory of insanity. It's just not a scientific statement. And so it was reborn in 1987 to help sell Prozac, but it was reborn as a marketing slogan, not as a scientific slogan. And the other thing that you have to understand then is if you don't start off with a serotonergic problem when you're depressed, right? You don't have low serotonin, but now you put yourself on a drug, okay? And this drug blocks the normal reuptake of serotonin. Your brain actually will undergo changes to try to compensate for that blockade. Mm-hmm. And what happens? The brain changes in two ways. The presynaptic neurons actually put out less serotonin, and your postsynaptic neurons actually pare away the density of their serotonergic receptors. So you start out with a normal serotonergic system, you go on an antidepressant, and you actually physiologically end up in a low serotonergic state. This is very well understood. So in essence, I know this sounds ironic, the drugs cause the very thing that was hypothesized to cause depression, and that is sort of this low physiological state. And the reason for this, it's well understood, is that, say for this example, the drug is trying to put down the accelerator on serotonergic transmission, and the brain tries to adapt to that by putting on the brake. So it's a compensatory adaptation. And just final thing, so your listeners don't think this is just one medical journalist saying this. Mm-hmm. In 1996, Steve Hyman, who was then head of the NIMH, okay, today he's provost of Harvard University, he's a neuroscientist. He published this paper called Initiation and Adaptation, a Paradigm for Understanding Psychotropic Drugs. And here's how he said that drugs like antidepressants work. He says they work by, quote, perturbing neurotransmitter systems, not balancing them. And in response to that perturbation, he said the brain undergoes these compensatory adaptations that I've just explained. And then he says at the end of this adaptation, the brain is operating in a manner that is both, and I quote, both qualitatively and quantitatively different than normal. So these are not normalizing agents. From a scientific point of view, really they are abnormalizing agents. And once you understand that, you can understand why maybe they might provoke a manic episode, why they might be associated with sexual dysfunction. violence, akathisia, etc., is because they in fact are abnormalizing agents. And you can also see why long-term, once you have this new way of operating with the accelerator down in one hand and the brake on the other, that you might have cognitive problems long-term because you're going to get some dysfunction in those serotonergic pathways. So this is really key. Are these normalizing agents? No. Are they abnormalizing agents? Yes.
Yeah, the ultimate irony is that the drugs are causing the very things that they were designed to cure. And for our listeners, I'm not sure if we mentioned it earlier, but you've mentioned a few times the NIMH researchers, and for those who aren't aware of that, that's the National Institutes of Mental Health, one of the most prestigious institutes in the United States, and typically associated with impartial funding, so that hopefully their results are unbiased and unprejudiced. What you just discussed too is with how the research was focused on the serotonin receptors, but I'm assuming there's similar effects for the dopamine or the norepinephrine receptors too.
Yeah, basically what Stephen Hyman was saying, this is how you have to understand all psychotropic drugs, is they perturb something and it provokes an opposite response. And I'll just give you an example. Antipsychotic drugs block dopamine receptors in the brain, and they do this rather powerfully. They block, say, 70% of D2 receptors. Well, what does the brain do in response to that blockade? It says, I'm going to try to maintain my dopaminergic pathways. The presynaptic neurons, at least for a time, pump out more dopamine, trying to compensate for this blockade. And the postsynaptic neurons increase the density of the dopamine receptors. So it drives the brain into, quote, a dopaminergic the brain becomes super sensitive to dopamine. And believe it or not, researchers have found that over the long term, that probably increases the biological vulnerability to psychosis. This is the problem with this whole paradigm of care. We don't know what's wrong. We don't know what the biology is. So the drugs perturb some functioning, and then the brain tries to compensate for that perturbation. And long term, it turns out that is a very problematic model.
It is. I mean, this is some very interesting and compelling research that you've really explained to us. And the typical person in the United States, the average consumer, is, my guess, under the impression that most researchers and scientists and physicians are well-intentioned, unbiased, and unprejudiced, and they're really seeking to provide the best possible care. Unfortunately, this doesn't appear to be the case. Otherwise, this information would clearly change the system that we're doing. I'm wondering what type of factors you've uncovered that prevent or limit implementing this understanding of what the drugs are doing.
Yeah, this is a really interesting story because, by the way, I agree with you. I think most doctors do want to do well by their patients, right? Mm-hmm. And I think actually many psychiatrists believe that their drugs fix chemical imbalances because they actually haven't looked at the research.
Yeah, we're both in agreement. There is not some type of conspiracy on physicians or psychiatrists. They do believe what they're doing helps.
That's right. But what happens at the very top levels and sort of psychiatry as a field? And here's what happened, because there is a historical story as to why our country is deluded, our society is deluded, and believes in this chemical imbalance story. In the 1970s, psychiatry as a discipline felt it was under siege. And it felt it was under siege because there were a lot of other therapists entering the, quote, therapy marketplace, social workers, counselors, psychologists. And they suddenly felt they were in competition for patients. That's the first problem. The second problem they felt is, in fact, their first generation of drugs was sort of failing in the marketplace. Benzodiazepines for anxiety were being seen as addictive and very harmful. The antipsychotics were seen as causing a permanent brain dysfunction called tardive dyskinesia. And sales of psychiatric drugs actually declined from about 1974 on for the next 6 years. And psychiatry sort of circled the wagons, and they said, well, how can we revive and strengthen our field? And they said, well, what gives us our competition in the marketplace? It's that we have prescribing powers and these other therapists do not. So there was a sense as we have to revitalize the image of psychiatric medications in the public mind. And they did this starting in 1980 with the publication of DSM-3, which put psychiatry and psychiatric disorders into a medical model. They started touting this story. these illnesses are known biological illnesses, and our drugs are like insulin for diabetes. They fix those, biological ailments. But that was all really done to sort of revive the market for psychiatric medications, and it was done sort of at the highest levels of American psychiatry. And in fact, and I do this in the book, you can even chart how in 1981 the APA, the American Psychiatric Association, set up a publicity arm and basically to start selling the public on this medical model, and it was to revive and protect the market for psychiatric medications. That's the first problem. In other words, there's this competitive thing where psychiatry needs to make its drugs look good in order to maintain its advantage over the non-prescribing therapist. The other thing that happened, and this really is problematic, is that in 1980, the American Psychiatric Association, at its annual meeting, started allowing pharmaceutical companies to sponsor symposiums. They'd always been allowed to, put up exhibits on the exhibit floor, but now they were actually allowed to sponsor scientific, quote, presentations. At that point, they began hiring academic physicians, people at major medical schools, to serve as the speakers at those events. And this is where the wall breaks down between academic psychiatry and the pharmaceutical companies, because now the top doctors in the country, the top psychiatrists, are going to start becoming paid to tell a story that pharmaceutical companies basically want told. And pretty soon they're serving as advisors, they're serving as consultants, they're getting research grants as speakers. There's a lot of money flowing to, quote, the thought leaders in psychiatry or the key opinion leaders. And in essence, they become the salesmen for these product lines. And they're very effective salesmen, and they have basically created this false story. And unfortunately, they get paid, they can make a lot of money. I mean, we're seeing this, some of the amounts have been come out through Senator Grassley's investigation. We're talking millions of dollars going to the top key opinion leaders within psychiatry. So that's how come we got this delusion. We had these storytelling forces within society come together that wanted to tell a story of drugs that were safe, effective, wonder drugs that fix chemical imbalances. And unfortunately, that story was out of sync with the research. It's just not a scientific story.
That's some very impressive information, and many of our listeners are not aware of that. And thank you for sharing it, because it does provide an important piece of information that most people are not aware of, and that there's reasons for what appears to be irrational choices that are being made in prescribing these drugs.
Yeah, I mean, you got to follow the money, and you got to look at what monetary forces shape these storytelling forces in our society, and you can shape them, how they took hold in the 1980s, and how, of course, we've embraced this model of care. I mean, here's, in 1985, when this sort of storytelling coalition took hold, the country spent about $600 million on psychiatric medications. Today we spend over $40 billion. The market has grown something like, 70 times. It's really astonishing. And by the way, we in the United States, think of this, spend more on antipsychotic medications than the gross national product of Cameroon.
That's quite startling, but $40 billion, I didn't realize it had grown to that much.
It's grown to that much. If you look at all psychiatric medications, it now tops $40 billion in the United States.
And my guess is that the new health care plan that the president was able to push through is going to rapidly accelerate that process.
I think probably so, because there's even some sense of parity for for psychiatric diagnosis.
Yeah, it's sad too, but hopefully as we move more towards a socialistic model, we'll be able to inject some sensibility into the system, like they've done in Great Britain or England, and start using exercise as a valid option. Because what I failed to mention, all these lifestyle changes that are being recommended for depression, such as the diet and the exercise, they're not exclusively limited to mental illnesses. They will improve every other chronic degenerative disease that we know of: heart disease and cancer and arthritis and diabetes. I mean, this will get all these diseases better. So it's not just mental health.
Well, I do believe mental health is related to physical health. So any sort of lifestyle changes that improve your physical health, and it's going to help your mental health as well. One thing on this, Like I said, I've been covering medicine science for a long time, and I'm a big believer in evidence-based medicine. And the book that I wrote really is looking at, what is the evidence base for psychiatric medications, and I've been telling that story. One of the reasons I write about in the solution sections about evidence is that there's a good evidence base for it. By that I mean it's been tried, tested, and it shows to have this benefit over long term. I'm not at all familiar with the literature on, dietary or, omega-3, et cetera, and you can address that. But I think in order to help, convince the public or help the public understand the benefits of these alternatives, you need, hopefully, good studies that can sort of document that in an evidence-based way. And I don't know if it exists or not. I researched it for exercise, but I haven't done it for other alternatives.
Well, it does certainly exists for the omega-3 fats. Where the literature is somewhat sparse because it just started the trials, and this is largely related to the lack of funding for these types of activities, would be the use of energy psychology techniques. There's really only a relative handful of studies that have been published, but they clinically and anecdotally work quite phenomenally well. I mean, they're nothing short of miraculous from what I've seen. It's the closest thing to magic.
Right. Well, I guess just because of the history of medicine and all. As you know, the history of medicine is filled with a lot of remedies that for a time are sort of touted as very effective, and then they don't have staying power. And it helps a remedy have staying power if it can be put sort of to the usual, and I understand there's a lack of money for it, but sort of the usual trials that can create an evidence base.
I couldn't agree more. And eventually that literature will exist, but in the meantime, there doesn't appear to be good scientific support for continuing a flawed system, which will not only be ineffective at treating the symptoms, but B, more importantly, make the problem worse in the long run.
Well, and the evidence is really clear on this. It's not that depression has become less of a problem in our society. Mm-hmm. The disability numbers to depression are just soaring. In fact, if you look at one of the things I looked at in this book, is the number of people on SSI and SSDI. This is government, disability programs due to mental illness. This is, people who can no longer work and they get a check. Well, first of all, when Prozac was introduced, there were 1.25 million on government disability due to mental illness. Today, 20 years later, during this time our spending has, exploded, there are 4 million people on disability. The number of people going on disability is increasing, adults at the rate of 850 people per day, 365 days per year. Very few of those people are now getting off once they go on. And if you look at what's driving the increase, it's not psychotic disorders. It's mood disorders. It's depression and bipolar illness. And it used to be very few of those people ended up on long-term disability. So here we have this new embrace of a medication that is said to be a wonder drug. And what do we see? We see disability rates due to depression and disability rates due to bipolar illness skyrocketing.
Yeah, we're definitely a direction we don't want to be heading. Like most areas in life, an ounce of prevention is worth a pound of cure. So I'm wondering, from the research you've reviewed and compiled, if you can provide our listeners with some of the warning signals of depression. It's not just feeling blue. Well, it certainly can be, but there's very specific symptoms. It's a real clinical entity. So I'm wondering if you can.
Well, I'm sure you can do this better than I can.
Well,
actually, but I mean, I'm sure you can do this better. What you'll see, in my opinion, when you look at sort of pathways to depression, you often do see environmental triggers, and by this I mean a loss of a job, a marriage breaks up. A loved one becomes sick. There's these stress triggers. You'll see a lack of sleeping is a big trigger, that something's not going right. You'll see, depression and anxiety are very, those are very connected. You'll see people getting anxious as well. So environmental triggers, insomnia, anxiety, sort of appetite changes, and also if you'll see that you just don't want to be among people as much, sort of withdrawal. I mean, all those are things that you're sort of heading a little bit for a fall, and that maybe if you can make changes before the fall really hits, you can sort of head off the depressive episode.
Yeah, I just reinforce some of the elements you said. I think from my perspective, sleeping is clearly a key issue. If there's not some type of sleep disorder, it's really hard to to really qualify as depression, although clearly you can be depressed without that. But it might be inability to fall asleep, or you might be sleeping all the time. Lack of interest, diminished interest, feeling guilty, inappropriate feelings of guilt, loss of energy and feeling tired. It's like if you have no energy would be another major clue that something's going on, and the appetite. When you lose most of the time you're going to be hungry, but if your appetite goes away on a persistent basis, you've got to start thinking about some of these things. And then the obvious and most significant one is suicide.
Right.
People do die. I forget what the numbers are, but I think it was somewhere about 30,000 a year. It's 100 people a day.
Yeah, that sounds about right. Yeah.
Yeah. So that's a lot of people. That's a big plane crashing every day of people killing themselves from suicide.
Right. No, and when you put it in that framework, it's obviously something we need to be paying attention to and trying to help people that hit that suicidal moment.
So, this is pervasive. It affects pretty much most every one of us at some point or another. Not necessarily a major episode of depression, but, where we're feeling, it's a spectrum, and maybe it just might be a few days or so where we're not feeling that great, and we get over it quickly. But this is an area that is significant and a concern, and I really appreciate all the time, effort, and energy you went into compiling this information to document that the traditional approach that is typically and routinely recommended is one that needs more serious evaluation if you're going to choose that, and to do your homework and certainly, if not for yourself, for your loved ones, your friends, your family, that there may be better options. Now, I guess one caution is that the majority of people who might acquire this information is that they're not in the episode where they're suffering from the initial symptoms of depression in the proactive preventive stages, but they already have it, and they've been placed on these medications perhaps for years or decades. So that presents a different challenge.
Yeah, it does present a different challenge, and to be honest with you, a worrisome challenge. I mean, there is some evidence that, really pretty consistent evidence, that the longer you're on antidepressant medications, frankly, the harder it is to get off. In other words, your vulnerability to relapse when you come off becomes, it increases.
The perfect drug from the drug company's perspective.
Well, yeah, there's a sense there's a trap. Yeah, I mean, they are a perfect drug in the sense that, let's say they do. Okay, let's say you have this sort of 6-week relief of symptoms, right? But then you become sort of depressed again. Well, the problem, and you see this, by the way, in the ads about how often frequently become depressed again. Television ads now, we have this new ad for Abilify, which is an antipsychotic. It says, 2/3 of people with an antidepressant are still depressed. Now add a drug. Well, you want to say, well, apparently the drug's not working too well if 2/3 are still depressed.
No, but that logic is too rational.
That is too rational.
Escaping our perspective.
But no, there is a real concern here, is that they are sort of a trap, because your brain goes through this compensation, this adaptation, and now let's go back to the accelerator brake analogy. So you've been on drug, and the drug is trying to put down the accelerator of serotonergic activity, and your brain responds by going through these physiological changes that put down the brake. Now imagine what happens, and this is what happens when you go off the drug, you remove the brake. Well, now you're in this unbalanced state where you have the drug still trying to accelerate activity. Anyway, it's quite clear that when that happens, you can have some very severe withdrawal symptoms, and it's not just symptoms of depression returning. You might have all sorts of odd symptoms. And then what happens is withdrawal can be so difficult that people just say, oh, heck, I'll just stay on my drug.
Right.
So that's a real problem in the way that the drugs can act like a trap, and I do believe the longer you're on, this isn't well studied, but the longer you're on, the harder it is to come off. And really, there's some sense the harder it is for your brain to sort of renormalize and receptor densities to return to normal and all. Well, I wish we would study this, but we don't really know a lot about, long-term what happens after long-term on the drugs, and your chance, what happens when you withdraw at that time.
Well, that information is strong support for a cautious approach to discontinuing these drugs. And this is not something you want to stop because you're concerned about the long-term dangers by yourself. You really do need to do this with a qualified and knowledgeable clinician. Now, my perspective is that most physicians will be able to titrate you off of these drugs, but they're based in a model that's going to want to replace it with another one. So more than likely, you're better off seeking a clinician who's rooted most of his framework and understanding in natural health and using natural healthy options such as the dietary changes, the exercises, and some of the energy psychology approaches to do this carefully. But in any way, you just do not, and I want to emphasize that a lot, you just do not stop these medications cold turkey. You are just asking for trouble. You can, most of the time, wean off of them slowly. It might be a few weeks, it might be a few months, but you just got to go off of them slowly.
Well, that's surely what the scientific literature shows, and I interviewed a number of patients, and they reiterate that as well. How hard it is. You just don't want to be going off abruptly. But the other thing you said, I think, is important. It can really be helpful to have someone supporting you and watching you, and sort of helping you understand. I'm talking about if you're weaning yourself from medications, and helping you understand some of the symptoms you may be feeling may be related to drug withdrawal, and give you some sense of how long you may be experiencing those withdrawal symptoms, because you can have withdrawal symptoms even when you gradually withdraw. So I think your message about having some professional support is a very good one.
Yeah, and it doesn't make sense to harness the placebo effect. And the placebo effect is not some type of nonsense. It's very real. And the most powerful demonstration of that is a study that was published I think in the year 2000, it was published in the New England Journal of Medicine, one of the most prestigious scientific journals, and it was a double-blind, placebo-controlled trial, multi-centered, and Harvard was one of the 6 hospitals where it was done. And they essentially looked at knee surgery or arthroscopy, and they did a placebo or a sham surgery where they inserted the arthroscope and did no surgical intervention. They just put the scope in, and I'm sure you've heard of it. And then they did another group where they actually did the surgical intervention. Right. And what they found was that there was no difference between the two groups. Right. Now, and that didn't mean that the procedure didn't work. To me, I mean, you could interpret it that way. That's one interpretation. My interpretation is that when you go through that type of intervention, and you can even use cardiac bypass surgery as another example, although it hasn't been studied like this, because of the ethics, I'm sure. But the central issue is that you can harness the power of your mind to accomplish incredible, miraculous transformations at a physical level, let alone the mental, emotional component, which is would seem to me far easier to do. But I mean, you can physically change your knee tissue. It certainly could change your brain, so that assistance with a really compassionate, supportive healthcare professional will help. And you may not even do it specifically for their purpose, but it's going to happen. That placebo effect will be activated, and you will get better just because of that.
Well, there's two things here. Yes, the placebo effect is powerful in many areas of medicine, both bodily and mental. But there's a real interesting history with active placebo in depression. Trials that have compared drug to active placebo. And an active placebo, rather than just being a sugar pill, is some agent that might cause dry mouth. That'll have some sort of side effect, okay? And when they've done trials that compare active placebo to drug for depressed patients, time and time again, there's no difference at all in the even in the short-term results. And what researchers who did these studies in the 70s said, what appears to be happening is the side effects enhances on the active placebo enhances the normal placebo effect, because people get the dry mouth and say, aha, I must be getting the magic pill. Mm-hmm. So once you have that effect going in an antidepressant trial, even over the short term, the antidepressant doesn't outperform the active placebo, and that led people to conclude in the early 80s, maybe these drugs they're not antidepressants at all, they're just active placebos at what makes them work. So that's one thing. But I would also caution there's another thing that I sometimes think it gets confused between placebo and natural recovery rates. So, because placebo, of course, is when there is an intervention, something's happening. But what is the natural recovery rate from depression? In other words, if you don't even have a medical intervention, but let's say you get it, you're in your house, and maybe you do make some changes in your life, whether it be go for bike rides or maybe a job happens or whatever. But my point of this is the human being does have sort of a natural capacity to recover from a lot of emotional states. And so that's beyond the placebo effect. So when we think about whether we need to take a medication, especially long term, you have to think both of the placebo effect, but you also want to understand the sort of baseline natural recovery rate. And for many mental disorders, that baseline recovery rate over the long term, including depression, is quite good.
The natural. I think that's a clear point to emphasize: is the natural recovery rate. This is pre-intervention with these drugs, because the longer you've been on the drugs, the worse that recovery rate's going to be.
Well, exactly, and that's one of the things again that comes up in the depression story is the NIMH. If you had become depressed in, say, 1970, and you had gone to NIMH literature, you know what they would have told you? The NIMH literature, whether you get treatment or you don't get treatment, you're going to get better, okay? And you have every reason to believe it will not turn chronic, because it's only a small percentage of people who end up with chronic depression.
What was that percentage? Was it under 5%?
Well, no, it was about maybe 10% of people entering with a major. We're talking about hospitalized depression, okay? Even the epidemiological studies of people so depressed they're ending up in the hospital. Even among that group, it's only 10, maybe 15% ending up with some sort of chronic long-term course.
Wow. So, I mean, that's another piece of good news. I mean, it's a really powerful piece that I frequently forget to mention, and is to emphasize that you're going to get better as long as you don't choose the drug.
Well, it is a very optimistic thing that I think, and right now people are said, take the drug and you're probably going to become chronic anyway. But yeah, the natural history message is a very, very optimistic one. I'll give you. Here's what the NIMH said in 1974 to depressed patients. This is from Dean Schuyler, head of the depression section at the NIMH. As he wrote, most depressive episodes will run their course and terminate with virtually complete recovery without specific intervention. That's quite optimistic. Here's another one from in 1969, an NIMH publication. Assurance can be given to a patient and to his family that subsequent episodes of illness after a first depression will not tend toward a more chronic course. So here's another one. Depression is, on the whole, one of the psychiatric conditions with the best prognosis for eventual recovery with or without treatment. Most depressions are self-limited. Wouldn't that be nice to hear today?
Yeah, well, it's going to be heavily suppressed by the drug companies, that's for sure.
Yeah,
they do not want that message out.
No, of course not.
So, I mean, the message that needs to be shared is the one that you've really compiled and put together and really reinforced, is that you just, I just got to avoid these medications. I mean, now you studied this really carefully. I guess the fear is, as a physician, that are there any indications, is there any subset of patients, however remote or rare, that may benefit from these drugs? Do you think they're ever clinically indicated?
No, I do.
Okay. All right. Good. So let's tell us who those people are. Because let me give you an analogy. I for the most part, I believe almost all statins, the drug used to lower cholesterol, are absolutely dangerous and should be avoided by almost everyone. But there's a small subset of people, about 1 in 1,000, who have a genetic disease. It's called familial hypercholesterolemia, and their cholesterol is usually run about 350 or so, and they seem to benefit from it. But that's 99.5% of people not needing it. So who are the people that you, in your evaluation review, suggest benefit from these approaches?
Well, let's show who shows up in the short-term clinical trials. There is a subset that really does do better than placebo, okay? And that's those with severe depression. So they're on the Hamilton scale. They're at a number that puts them in, quote, the severe category. And over the 6 weeks, they do seem to have, an abatement of their symptoms that's clinically significant more than placebo. So, and this, again, is what the National Institute of Clinical Excellence in Britain concluded, is that shows there's some rationale for using it in that using antidepressants in that subset of depressed patients, even sort of as a first-line therapy. And then I think once you see that rationale for use, I think you still want to look at the long-term outcomes, even in severe patients. And given that in the pre-antidepressant era, severe patients regularly did, get better and stay better. And by the way, the NIMH looked at this in the late 1990s. What is the untreated course of major depression today? And they found that those old epidemiological studies that showed that 85% were well at the end of a year still held true. You want to remember that. So I think the rational use would be in this subset would be, okay, use it to help people get out of the severe symptoms on a short-term basis. And as that happens, help them encourage to make changes, whether it be diet, exercise, get into community groups, join clubs, whatever it might be, and then help them wean off. Try to help them wean off after 6 weeks, 8 weeks. So use them as a short-term crutch. I think that makes sense.
Yeah. So, and I like the term crutch because it really applies in the image of an acute injury, like you're in an accident or you fall on the stairs and you are physically wearing a crutch, and allows your bone to heal in that time frame. And after that time, you don't wear a crutch the rest of your life, or certainly for months, typically.
No, exactly. And so I think if you had a paradigm of care that said, okay, let's throw away the crutch and get people back to a non-medicated life, that would be terrific. And then the drugs would have, I'm talking about the SSRIs, and you pay attention to all their side effects and the risk of mania, and then they'd have a sensible, thoughtful use in place.
I like your approach, and I appreciate all you've done for helping us understand this at a deeper level. Are there any other pearls or wisdom that you'd like to share from the information you've put together?
Well, no, I just think the bottom line is this, is that, and when we're talking about antidepressants, people need to broaden their horizon in terms of as they try individually whether or not to go this route. And they've got to broaden their horizon that includes long-term effects, risk of mania, risk of cognitive decline, and incorporate that into their decision-making process. And I think if they did so and see this long-term chronicity, people would be making different decisions. And last thing is this. The one thing, it seems to me, of people I interviewed that got better, and that depression is gone, they talk about sort of the agencies, sort of making changes in their life that gave them a sense of control over, a little bit of control, and I'm not saying, control over their well-being. And I think anything that encourages that sense of control, that you can do things to at least minimize the risk, is a very good thing.
Excellent. Well, people want to learn more about the specifics. I'm sure they can look at your book. And can you give us the name of that book again? And I'm sure it's on Amazon.
Yeah, it's called Anatomy of an Epidemic. And again, my name is Robert Whitaker, so you can order it there, or you can go to Barnes & Noble or Borders, and you should be able to find it there as well.
Excellent. Well, thanks for all the work you've done, not only for this book, but for the many years you've put in to help educate us about the truth, and that really is clear. And that's one of my passions too. I'm a medical journalist, even though my initial training is a physician, but I'm a medical journalist and trying to help people understand, because they're just our lives are busy. The economy kind of is tanked, and we've all got things to keep us occupied, and we just don't have the time, which is really the key limiting resource for most of us, to evaluate these things like we need to, and it takes a lot of time to do that. So I really appreciate all the time you invested in helping uncover this, because it's a big story and it needs to be shared. So thanks for all you did.
Well, thank you for having me. It's my pleasure being with you.
Thanks for watching. Subscribe now and click the notification bell so you never miss an update. See you in the next video.